Welcome, and thank you for joining Landmark Changes in Asthma Management, the power of brief interventions for pharmacists as partners in asthma care. My name is Dr. Anne Ellis. I'm Professor and Chair of the Division of Allergy and Immunology at Queen's University in Kingston, Ontario, and I've left my contact information here for you if there are any questions you have after the presentation. Just for reference sake, today is June 30th, 2020. In case any of this information changes over the course of the year, you can reference it back to it being current as of this date. These are my disclosures. What's most important to disclose is that I have received a speaker's fee from the Ontario Pharmacists Association for this learning activity, and that this learning activity received financial support from AstraZeneca in the form of an educational grant. There's a number of abbreviations that are used throughout the presentation, so I've highlighted these for you here. Saba stands for short-acting beta agonist. ICS refers to inhaled corticosteroids. GINA is the Global Initiative for Asthma. The Canadian Thoracic Society is referred to as CTS. And then my colleague Dorothy will be using DTP for drug therapy problems, MDI for metered dose inhaler, and DPI for dry powder. Our objectives really are to describe current global recommendations to help minimize the overuse of short-acting beta agonists as monotherapy and optimize controller therapy. So this idea came actually from a national steering group called Asthma Zero that was established in 2018 in response to a call for action to have zero tolerance for asthma attacks by the Lancet Commission. There's a multidisciplinary membership of this group that includes patient groups as well as physicians. The goals are that the ministries of health, insurers, disease organizations, and healthcare professional associations prioritize the management of asthma for a significant reevaluation and overhaul, encourage zero tolerance for asthma attacks among people living with asthma in clinical practice, especially regarding SABA over-reliance and ICS underuse, and finally to support the implementation of pragmatic solutions in asthma management to account for patient behavior. This is our group. I serve as a steering committee chair. We have representations from emergency medicine, respirology, family physicians, other allergists, and we also have representation from the CEO of Asthma Canada as well as the Lung Association of Ontario, and of course Dorothy, who co-developed this project with me, who is our pharmacist team member. So why are we still talking about asthma today? Well, in fact, almost 2.5 million of Canadians are reported having been diagnosed with asthma, and in every day, over 300 people get this as a new diagnosis, and almost 300 people present to the emergency department for their asthma attack. The economic burden of asthma is estimated at over $52 billion annually in Canada. Prevalence of asthma increased significantly over the past 20 years up until 2001 when it finally plateaued and stabilized, and such that 8% of adults have asthma and at least 12% of children have asthma. So let's make sure we're talking about the right disease. So asthma is a chronic disease characterized by inflammation and episodes of increased symptoms and exacerbations associated with worsening inflammation. So again, the diagnosis comes from the clinical history with support of lung function, and we characterize it by symptoms and severity, but not the underlying pathophysiology. Traditionally, we've divided management strategies for asthma into medications that we consider the controllers and the relievers. The ones that target the inflammation being the controllers, and the ones that target bronchoconstriction being the reliever. However, it's important to recognize that it's actually the inflammation in the first place that causes the bronchoconstriction. So it's key to make sure we're hitting this side of the equation and not just relying on things that open up the airways. Again, asthma is a disease of chronic inflammation with times of periodic worsening and periodic acute inflammation. You get this acute on chronic inflammation during times of asthma attacks, and all along, if you're not controlling the inflammation, this will lead to structural changes, airway remodeling, and gradually a reversal of the inability to make that reversal happen with the bronchodilator. So we face 5 paradoxes in asthma management that all lead to this over-reliance on SABA and underuse of ICS. The first one is that according to the GINA criteria we followed in 2018, step 1, which is the mild intermittent asthmatics, we're recommended to just use PRN SABA only, despite the fact that we know this is a disease of chronic inflammation, but we're letting people take something from time to time that doesn't target the inflammation whatsoever. So not surprisingly, when people who have been using their SABAs frequently and we realize, oh, you're now in step 2, that means we have to step you up to a regular dose of inhaled corticosteroid. The patient is not alone longer in that concept of, I'm going to take something when I feel symptoms. And so not surprisingly, when they go to start taking an ICS regularly and they don't notice immediate relief, they quickly say, forget this, I'm going to go back to that medication that was actually helping me. And they can't help but just continue to go back to their SABAs because that's the one that gives them relief. And so therefore they perceive that as being the medication that's actually helping them. So it's very hard to get people to switch from use this inhaler whenever you feel like you have symptoms that'll make you feel better to, oh, don't use that one at all. Try to use this one as much as possible and you minimize your use of that other one. It's very hard to make that shift. Up until recently, we also had this issue with safety messages on SABA and LABA being conflicting. So up until very recently, any product that contained a long-acting beta agonist or a LABA had a black box warning from the FDA saying that it was shown to be an increased risk of death. In fact, the issues around increased mortality from LABAs came from a study where they were used as monotherapy, the so-called SMART study, which wasn't so smart in the end. When it was paired with inhaled corticosteroids in a single inhaler that contains both an ICS and a LABA, there was no reason to believe that this led to any increased mortality. But it wasn't until all the companies who made these fixed-dose inhalers with ICS and LABA paired together conducted 4 very large phase 4 trials with thousands of patients enrolled to prove the safety of LABAs when used in combination with an ICS. So that's finally been removed from the label, but that only happened very recently. So up until recently, when people would get their prescriptions for their ICS LABA, they would see that increased risk of mortality and say, I don't want to take this. I don't want to take something that's going to increase my risk of death. But yet there was never any such warning, and still isn't today, on a prescription for a SABA. So if you take your of Ventolin and you read the product monograph, there's nothing that says overusing this could lead to death, at least not in a black box warning type way. So patients don't have that same perception of a safety problem with their SABAs as they up until recently were perceiving with their LABAs. And finally, something we're not going to dwell on too much today, but there's been this forever disconnect between a patient's perception of their asthma control compared to their actual symptoms. Again, asthma is a chronic disease. Patients normalize their symptoms. They think it's normal to wake up every morning and have to take a puff of Ventolin. It's actually not normal. It means it's not well controlled. But if somebody's had this for a long time and they don't maybe even know better, then you can wind up believing that your asthma is fine when in fact it's uncontrolled. So why do we have this paradox? Why do patients persist in not taking their asthma medications the way we prescribe them? Well, not surprisingly, most people don't want to take medications on a day when they feel well and have no asthma symptoms. Many believe they feel like they know when they need to take their asthma medications. Most use SABAs because they work quickly, it gives them the relief they need, and they can go on about their day. And many of them just don't know or believe that current asthma control results in future risks. And there's a big education gap that our physicians have to spend enough time to make sure they understand what the nature of their disease is. So instead of just simply saying, how's your asthma doing? Because usually the answer will be, it's fine. It's important to go through some of these questions. Your asthma control check. Do you have to use your reliever inhaler 4 or more times per week? Do you have symptoms 4 or more days a week? Do you ever have difficulty exercising or playing sports because of your asthma? Do you wake up 1 or more nights a week because of asthma? Have you missed work or school? And finally, have you had flare-ups recently? And these are meant to align with the Canadian respiratory guidelines, where we want to see that you're having daytime symptoms less than 4 days a week, you're using your reliever inhaler less than 4 doses per week, you're not having nighttime symptoms, you have normal physical activity, and you're not missing work or school due to asthma. That's the definition of controlled asthma. The GINA assessment for the level of asthma symptom control is a little bit simpler, and it breaks it down into 4 simple questions. In the past 4 weeks, have you had symptoms more than twice a week? Have you woken up at night at all due to your asthma? Have you needed to use your reliever more than twice a week? And finally, any activity limitation due to asthma. And if you're well controlled, the answer is no to every single one of those questions. Once you answer yes to 1 or 2 of them, you're only partly controlled. And if you have 3 or 4 yeses, then that's uncontrolled asthma. This is a study that was done by Mark Fitzgerald quite some time ago, but the message still resonates. If you just simply ask people, how is your asthma? Is it controlled or is it uncontrolled? 97% of these patients thought their asthma was just fine, when in fact, if they did that asthma control test questionnaire that I showed you at the beginning, over 50% of them were not in fact controlled. The problem is that the doctors looking after them weren't that much better either, where 80 to 90% of the physicians looking after them thought the patients were well controlled, that in fact were not. It's important to realize that this happens at all levels of severity. So nobody's very surprised that 84% of people with the most severe asthma at step 5 here is uncontrolled. But take a look at step 1 and step 2. These are our mild and mild to moderate patients. And yet here they are, 43 to 52% of them actually have uncontrolled asthma when you go through those questions in a rigorous way. So that shows us that we can do better. And there's this window of opportunity where you can really jump in and try to prevent an exacerbation. Because what happens is that the first signs or warnings of their asthma starting to act up, what happens is they're very, very quick to increase their number of inhalations per day of their short-acting beta agonists. And when they're at the peak of their exacerbation, it's only then that you see that rise in their use of their ICS. So we've got use of Saba on the left here, use of ICS on the right. Look at this, early signs and warnings. Yep, Saba goes right up. There's no change at all in their controller therapies. So they're not activating their action plan soon enough. And it's not until they get to the peak of their symptoms that they're actually increasing their ICS, if they are at all. So we have this early warning period where maybe we could step in and stop them from having to go up to using 4 to 5 puffs of Saba per day. Well, what's the big deal about overusing Saba? Well, in fact, we know that over-reliance on Saba at the expense of ICS controller therapy is associated with an increased risk of asthma-related death. And it directly correlates to the number of Saba canisters you go through. The more you're going through your Saba canisters, the much increased risk in mortality, and it certainly declines dramatically if you're adherent to your ICS. And the inflection point is 6 here. Even if you're only 50% adherent to your ICS, we see a significant reduction in the risk for death due to their asthma. So this is what made people really step back and think about what are we recommending in GINA. Because GINA 2018, step 1 was still looking for patients with symptoms less than twice a month. There was no controller therapy recommended. Saba PRN was acceptable strategy. And that's now outdated, and we're not following that anymore. Because in 2019, there were landmark changes for asthma management because for safety reasons, GINA no longer recommends Saba-only treatment for step 1. This decision was based on evidence that Saba-only treatment increases the risk of severe exacerbations and that adding any ICS significantly reduces the risk. So as a result, all adults and adolescents with asthma should receive a symptom-driven or regular low-dose ICS-containing controller therapy to reduce the risk of serious exacerbations at step 1. So you're either going to put everybody on low-dose ICS, but what's more likely to be followed is using PRN ICS containing low-dose ICS with formoterol. And again, this was decided as a population risk reduction strategy, such as how we give statins to everybody with diabetes, for example. So again, you can see here, step one, you're either going to use low dose as needed ICS formoterol, and your preferred reliever is low dose ICS formoterol. That means every time you're having something causing bronchoconstriction, you're also taking something that's targeting the inflammation that's driving it in the first place. And so this is what we're now recommending for all of our asthmatic patients. So what was the rationale behind this? So as I mentioned, now our preferred controller is either PRN ICS formoterol, or you can take ICS whenever you take your Saba. That's better based on formulary alternatives. So again, step one is for patients with symptoms less than twice a month and with no exacerbation risk factors. As needed, low dose ICS formoterol based on evidence from Sigma 1 of a large reduction in severe exacerbations versus PRN Saba only, and based on the values and preferences that we're giving a high importance to reducing exacerbations, to avoiding conflicting messages about the goals of asthma treatment between step 1 and step 2, and knowing that there is poor adherence with regular ICS in patients who have infrequent symptoms. So that means they're going to be at risk of using Saba-only treatment. The other controller option in step 1 is to use low-dose ICS whenever Saba is taken. And again, this is technically off-label, but it's based on indirect evidence from studies in patients eligible for step 2 treatment. Again, because we recognize that any ICS is probably better than no ICS, and we're trying to prevent severe exacerbations. And we recognize that it's not great to have to carry 2 different inhalers, but it's still better than just carrying a Saba. There are combination ICS Saba inhalers in some countries, but approved only for maintenance use. So even in countries that have those types of inhalers, which we don't have in Canada, it is only approved for maintenance use, so it is important to recognize that that's off-label. But no matter what, daily ICS is no longer listed in step 1 as an option because there is no point of recognizing that there's a high probability of poor adherence. So it's now replaced by the more feasible as needed controller options for step 1. In step 2, patients who are now having symptoms more than 4 times a week, you're going to move them up to step 2. Here we recommend either daily low-dose inhaled corticosteroid or again, PRN low-dose ICS formoterol. And where's our evidence? It comes from a large body of evidence, actually, of randomized controlled trials and observational studies that show that low-dose ICS substantially reduces the risks of severe exacerbations, hospitalizations, and death, and that serious exacerbations are halved even in patients who have a low burden of symptoms, and that we also see improved symptom control and reduced exercise-induced bronchoconstriction with low-dose ICS. Again, high importance was given to preventing asthma deaths and exacerbations. However, we're aware that poor adherence is common in mild asthma in the community, and this would expose patients to the risk of Saba-only treatment. So that's why equally recommended is as needed low-dose ICS formoterol. Again, the evidence here is strong from 2 large studies of non-inferiority for severe exacerbations versus low-dose ICS and as needed formoterol, and also from large study of showing a 64% reduction in severe exacerbations compared to PRN Saba. And again, not only are symptoms reduced, but we've also got another study showing reduced exercise-induced bronchoconstriction with ongoing PRN ICS formoterol. And again, the values and preferences were this high important to reducing severe symptoms. We recognize that patients who have mild or infrequent symptoms are not likely to use daily ICS and therefore would just rely on Sabas. And that we've got good safety that using PRN ICS formoterol does not put you at risk for exacerbations compared to people who are taking their ICS regularly. And we want to make sure that patients' normal behavior is to be giving yourself a controller at the same time you're giving yourself a reliever. It's this concept of an anti-inflammatory reliever. There are other options in step 2. Again, this is a global document, so recognizing that there may be alternatives that are easier to do in countries. So you can look at low-dose ICS taken whenever you take your SABA. This is what I recommend in my children now. And there is some randomized controlled trials showing benefits compared to using PRN SABA only, and showing fewer or similar exacerbations compared to maintenance ICS. And not surprisingly, this is because real adherence to maintenance ICS is extremely low. Again, the values were that there's a high importance to preventing exacerbations. We're recognizing there's an inconvenience to carry 2 inhalers, and where a combination ICS-SABA inhalers in some countries, it's only approved for maintenance use. The other option in step 2 is to take a leukotriene receptor antagonist. This has not been shown to be as effective for preventing exacerbations, but some patients who do respond to leukotriene receptor antagonists, they may prefer to take a tablet as opposed to needing to use inhalers. So the key messaging really to take home is that over-reliance on SABA is linked to lung function decline and asthma mortality. Pairing PRN SABA with ICS should lead to decreased airway inflammation. ICS adherence is still the optimal strategy if we can get people to take their ICS regularly every day, whether they feel like they need it or not. Real-world evidence shows this is problematic, and asthma patients tend to reach for their SABA first and restart their ICSs later. So where do we go from here? So ICS from 200/6 strength is now approved as an anti-inflammatory reliever in Canada for mild, persistent, moderate, or severe asthma patients. GINA 2019 allows for some ICS to be incorporated into therapy even for mild asthma. And Asthma Zero is spearheading a number of initiatives to find ways to reduce SABA overuse and ICS underuse. And we have a number of educational initiatives aimed at primary care, patients, and our pharmacist partners, which is why we're here today. I'd like to thank you again for your attentions, and I have left my contact information here if you do have any follow-up questions.